Good evening all. Okay. Now we have implanted in a routine cases toric IOL. Now there are some certain situations whether we are in a dilemma whether this patient is going to benefit from a toric IOL or is it appropriate for the patient to have a toric IOL implanted. So we'll just see some case scenarios. Now this 26-year-old man had undergone RD surgery following blunt trauma, and he comes back after 5 years with a defective vision of 6/36, and he had a posterior subcapsular cataract. So what is the problem is the patient has an encerclage done, and it is a post-equatorial position is a buckle. It's an encerclage, it's going to be a permanent thing. So if this patient is going to benefit from this toric IOL is our question. Since it is going to be a permanent, there is no harm in doing implanting a toric IOL for this patient. Actually, his point right. Actually, this patient has got toricity in both the eyes, and you can see the increase in axial length after the buckle. If it's an encerclage, it is okay, but if there is a radially placed buckle, you should be careful because that can again increase the astigmatism. In those cases also, it is again going to be permanent. Repeat the biometry, and if you're getting repeatably the same toricity, you can go for IOL implantation. And so the take-home message from this is corneal astigmatism stable, can go for toric IOL implantation post-RD surgery cases. Now this is a patient with a penetrating injury and he's got aphakia. He's got a PC dehiscence temporally with a PC rem nasally. So we had done a corneal suturing, and this is a patient's topography picture. You can see the flattening and the area of the suturing, and he's got an IOL power of 26 with a toricity of 2.36. He was a young man of 26 years. So we implanted a monofocal in the sulcus. Why? Because we are not supposed to implant a toric IOL in the sulcus, has a chance of rotation. Not only that, I don't think there's available 3-piece toric IOLs also. Never implant a single piece in the sulcus. Now, in case of PCR, if it is central PCR, if you can do a PCC, you can place a toric IOL in the bag with the haptics in the bag and do an optic capture at the PCC. But beware when you are rotating, the PCR can get extended. Similarly, when there is zonular instability, if you can put a CTR, make the bag stable, only then go for a toric IOL implantation, or please go for a monofocal IOL implantation only. Now this is a 72-year-old female. She had undergone cataract surgery in right eye with 6/6 vision, and she had keratoconus in the left eye. So when it comes to keratoconus, you be very careful. You can see the ring image of the irregularity, and this was her PG power. It was axis was at 90 degrees. But when we did the topography, you could see the axis was different, and she had about 9.47 of astigmatism, and this is her topography. So here the patient's topographically and biometrically the axis was same, but the acceptance was a different axis. So in such patients, we can implant a toric IOL with a word of caution telling them you can have a lesser of spectacle dependence, but we cannot predict the outcome in such cases. Thankfully, the patient herself requested me to go for a monofocal only, and she didn't want a toric IOL. Then this was a post-op, axis was again different. So in such patients, if a mild keratoconus and moderate keratoconus, if we have a central cone and repeatability of biometry is there, you can go ahead with toric IOL implantation. But if the K value is more than 50, it is better go for monofocal implantation. Now this is a young man with 22-year-old and bilateral keratoconus, undergone C3 2 years back. Patient developed posterior subcapsular cataract, and this was a patient's toricity. You can 6-cylinder in right eye and 8-cylinder in the left eye. So we told him we can go for a toric IOL implantation, but there can be a residual power remaining. You will have to go for a contact lens or glasses, whichever is acceptable. Since he had so much of toricity, we went for a toric IOL implantation for this patient, and he had a stable biometry and stable topography. So, and we made a custom-made lens of 7 and 6 diopter cylinder at the IOL plane, and the residual was corrected with a contact lens. So in keratoconus, as I mentioned earlier, with stable refraction, we can implant toric IOL and reduce the spectacle dependence and improve the vision. Now the 73-year-old male, he had come to a hospital for cataract surgery, and this was a K1 and K2, and this was axial length, but the Sherma was 0. And you can see the irregular Myers. So we, after using of lubricants, we could see the change in the keratometry value. And with this K value, we implanted the IOL, and the patient was happy, and the post-op vision was 6/6. So dryness is something which has to be addressed. The ocular surfaces should be addressed, and you must get a repeat and repeat biometry and plan accordingly. It should be very much repeatable, the biometry as well as the topography. Now, in case of rheumatoid arthritis, this patient had a PUK scar. So initially when we did a cataract surgery, she didn't have much of she had a cylinder but not much of toricity. So what we did was we implanted monofocal toric for this patient. Why? Because rheumatoid arthritis, there can be peripheral thinning and scarring, which is an ongoing process. So in such cases, better to go for a monofocal IOL only. So you can see the change. I don't have the first one. So you can see the change in the IOL power. Here, as you can see, the cylinder is increasing. So in such patients, go for a monofocal IOL only. So when you come to central corneal opacity, always check the pupil cornea corresponding to the pupil. If it is regular, that's important. If it is regular, you go for a toric IOL implantation. If the regularity is not there, please go for a monofocal IOL implantation. Let the scar be in the periphery. Again, check for the regularity at the pupillary area, cornea corresponding pupillary area, only then go for an IOL implantation. In this case, though, it was not, it was 134 and 44. Since it was encroaching the pupillary area, we went for a monofocal IOL implantation. Patient had only so much of cylinder. Now, this patient had undergone LASIK, patient developed ectasia, patient underwent phakic IOL implantation, and patient had come with NS3 cataract. So, we did an phakic IOL explantation and we did a cataract surgery, and this was a patient's best corrected visual acuity when he came to us. So, and this is a patient's topography picture. You can see the flattening following the LASIK procedure and posterior ectasia, and we implanted a two spherical equivalent of 2 and cylinder of almost 6 in the IOL plane, and the patient vision improved to 6/18. In all these cases, we can implant toric with a word of caution only. And this is another patient who had bilateral pterygium and both nasal and temporal. Patient underwent pterygium surgery. He came to us only after 6 months. So we had a repeated topo cylinder which was stable, and then we went for a toric IOL implantation. Again, it's very important, check for the repeatability. And the post-op patient was very happy. So in word of multifocal IOLs, when there is a cylinder power of more than 0.75, always go for a multifocal toric, or the patient will never be happy. And similarly, when you have a small pupil, toric IOL implant is very difficult. So initially, better avoid such cases. Later on, if you are very confident, you can use irrigation port and then use the dialer in the other hand and make sure the axis is aligned properly. This is a patient Dr. Sugandha had mentioned earlier, 42-year-old male. This was his retinoscopy values, you can see, and this was his IOL port is 29, and there was toricity also. We would implanted a toric IOL, but the patient was not happy, though his vision improved from 2/6 to 6/36, and even with the caution we had implanted, patient was not happy. So, word of that amblyopia should be mentioned to such patients whom we have so much of hyperopic correction in the wet retinoscopy itself. Thank you.